queries here? Anything? Let us just describe the boundaries of the canal, boundaries of the middle ear first. Try to remember the names and then you should not be confused among the things, okay? Let's see a big picture like this. So this is the pinna, and on the pinna you have helix, antihelix, scaphoid fossa, triangular fossa, incisura, lobule, and many structures. This is just a quick revision.
Yes.
Then here is the external auditory meatus. Meatus means opening. Then there is a auditory canal, okay, or auditory tube, no problem. Then we have a tympanic membrane.
Yes.
Tympanic membrane has 3 layers. One should be outer, from here is the skin. One from the middle ear cavity, because that is a cavity, it should have a mucosa, so mucosa lining from inside. And these are 2. And in between there is a layer which is the fibrous layer, connective tissue, to give it a strength. This is about the all the nerve supply, blood supply, you know now, and you have to read it yourself, because you will not find any visible blood vessels here or in the models. So we can ask you, like, this is the structure, what name, what are the attachments, what is the blood supply, like many related questions, and you know better than me now. You are best in the questions now. Alhamdulillah. So after this we have a middle ear cavity. What is middle ear cavity? Middle ear cavity is a hexagonal space. Hexagonal, I bring this intentionally today to show you. Hexagonal yani 6 walls. So it has a roof, it has a floor, it has anterior wall, posterior wall, lateral wall with the tympanic membrane, and medial wall. After that, here is the external ear. Then we have tympanic membrane. The other name is the drum, a tympanic membrane or ear drum. Then we have middle ear cavity, and then we have inner ear. So this is the sequence. Okay? Consider this as my middle ear cavity of this ear, and you will have a good idea. It's a hexagonal thing. So I'm seeing like here, and you are seeing my ear cavity like this. Okay? The ear cavity, middle ear cavity, is hexagonal. Now think again like this. So here what is the shape? I said it is biconcave and compressed. So from here it is like compressed. Good? So where is the anterior wall? Here is the anterior wall. We have 3 structures related to anterior wall. Anterior wall is known as carotid wall. Anterior wall has one opening here for tensor tympani. So tensor tympani will come and enter into the cavity with its tendon to be attached on the malleus. What it will do? It will come, tendon like come. Here is the tympanic membrane. Here is the malleus. It will pull and it will keep it like in a stretched form. Pars tensa is tense because of this stress. Clear?
Yes.
So this is number 1. Number 2, opening for auditory tube will go into the nasopharynx. Khalas. Number 3, carotid canal. When I was teaching you the skull, I told you carotid foramen, no carotid foramen. I said you carotid canal, because foramen is a thing like, okay, and carotid canal is a track like this.
Okay.
So with the anterior wall of the middle ear cavity, this carotid is not attached. It is far in front. But since it is in the relation, so just to memorize for you 3 structures, like one for canal here, one here, and one here. So you remember like this. This is for the anterior wall. For the posterior wall, what we have? Mastoid process. Remember, the mastoid process, this mucosa is continues back into the mucosa of the mastoid process. So this is the back of the ear, posterior wall. Here is an opening. Any opening in the body is called adytus. So this is called adytus to antrum. What is antrum? Antrum means a cavity. Antrum means a cavity. So adytus to antrum means opening to the cavity. Which cavity? Cavity of mastoid. How we see mastoid? We see mastoid process like this structure. Here is the middle ear cavity. I make it big to make you understand. So here is an opening on the posterior wall which is lining the mucosa, will enter here. Good? And this is going to have some, so this is the editus, yani opening. This is called editus. And on the back we have antrum, yani cavity of the mastoid. If you see the cavity of mastoid, this contains air. When the book says, yesterday one student asked me, I used the term mastoid air cells. He thought cells containing with air. I said no, the cavities, small cavities, like we have air cavities in the sinuses. So here are multiple small cavities. They are collectively known as mastoid air cells, and they communicate with here. The problem will be if we have a chronic otitis media, means chronic inflammation in the cavity here. It can spread and it can lodge, stay there for many longer time inside the mastoid, leading to a condition called chronic otitis media, leading to chronic mastoiditis. So this is one of the clinical importances. Am I clear up to this point?
Clear.
So this is anterior wall, you know now, the posterior wall, mastoid, antrum, air cells, and editus and cavity. Good?
Yes.
Before entering into the posterior wall, we have a extension of the cavity here. So mastoid should be here. We have above the mastoid some part. In another picture I will show you. And this is called attic part. No other significance except a potential space, bus, nothing else. Attic part. Then I finished the anterior wall, posterior wall. Superior wall or the roof. Roof is this one. A thin plate, you can see, appreciate. A very thin plate. And the name is tegmen tympani. It's a part of temporal bone. Similarly, floor is again a thin plate. Again called, jugular wall. And this is called tegmen tympani, the superior or the roof. The point here is both of them are very thin walls. Plus, both of them in children. Think of in children when there is no ossification in these bones. They are membranous. So any infection here or here or here or here can reach. This very thin structure is responsible if there is a fracture, rupture or a membranous area. This is related up to the middle cranial fossa. And here is the temporal lobe of the brain, very close to it. So we can have a direct meningitis effect on, or even encephalitis sometimes, may Allah forgive us. So this is, you know now, anterior wall, posterior wall, superior wall, roof and the inferior wall floor. Again a thin plate related to jugular vein, so we call this as jugular wall.
Okay.
So here is the jugular vein going down, internal jugular vein. The bulb is very close to it. If there is an inflammation here, it can create some exudation or something and can lead to thrombosis here. So we have to be careful. So you know now anterior, posterior, superior, inferior. The lateral wall, like pressed, like this is like cavity like this. The lateral wall is what? Tympanic membrane. So is it tympanic membrane? You know everything about tympanic membrane. Has two parts, pars tensa, pars flaccida. And what are the what are the other structures? You can see this is on the back of the tympanic membrane. Here is a tympanic membrane, and here is of course the malleus. Okay, from the malleus, the fold, what is going in front? Anterior malleolar fold. One going back, posterior malleolar fold. Combining or dividing whole of it into two parts. One this pars tensa, which is made tense with the help of tensor tympani muscle attached to the malleus, and it is being pulled. Clear? And that muscle is coming from the anterior wall, and then the tendon is going into inserted into the malleus, making it pars tensa. The above part, this all is called pars flaccida. It is not as tense as this is. Whenever there is any infection in the middle ear cavity, so you must have heard the term, there is a rupture in the tympanic membrane.
Yes.
So this is the likely area of rupture without other causes like infections may include, the causes may include like infections, causes may include like a slap, a football, a trauma, when you clean your ear with a car key. So these are all possible areas for damaging and rupturing, and this is likely area which usually ruptures because of the causes.
Does the rupture heal?
Does the rupture heal? Let us finish. Remember this question. Let us finish the anatomy, and I will come to the clinical issues. No problem. So this is lateral wall. You know the membrane. Medial wall. What is on the medial wall? If you go and see the medial wall, if you see this picture, this will make your life comfortable. Yes. If you see this picture, this is a cavity now. Covered with, I am inside the cavity, here is the tympanic membrane now. I should remove the tympanic membrane to see on the medial wall because this is the lateral wall. So once I remove the tympanic membrane, I will be able to see different structures. Some of them are impressions. When I say impression, what do you mean by?
Doesn't mean that
I see, for example, I say there is impression for facial nerve.
doesn't mean that it passes. It's just
It doesn't mean it passes through it, not the content. When I say impression, suppose this is this facial nerve, okay, and this is the facial nerve crossing. Here is the bone, and you have an impression like this. Am I clear up to this point? So this is the impression, but this is the content. So you will have three basic impressions. One is promontory. What is promontory? Promontory is the impression which is caused by the rounded cochlea. Good?
Right.
One part of inner ear. Another impression is bifacial nerve, which is present. This is which wall? The medial wall. So this impression starts in the medial wall, it continues in the posterior wall, and then it leaves here through stylomastoid foramen, and you know here is the styloid process and here is the mastoid process, and this is the picture of this area, and you see facial nerve getting out at this point. Agree? Here is a branch called cauda tympani, which is going to the tongue. How it should reach the tongue? So this is the impression, but cauda tympani is a content, because it has to reach here to get out and go to the other structures. Am I clear now?
Okay.
Good. So first impression you will find is promontory. The second impression is the facial canal. We say this structure as facial canal, which is, I have written in other slides, I will tell you, which is a bony canal containing facial nerve in the medial and posterior wall of the middle ear cavity. Am I clear?
Okay.
Then we have another impression here. Again impression, not the content. What is the impression? This is prominence of lateral semicircular canal. We have three canals like this. 1, 2 and 3 semicircular canals. So one of them, they have names. One of them is called superior. One of them is called posterior. One of them lateral. I will tell you in the models which is lateral and how to remember it. Okay? So don't press on your meninges hard. So this is the three impressions. Now we have openings. One is this oval window. Oval window is covered by three bones. Here is the tympanic membrane. To the tympanic membrane is attached this malleus. I cannot see from outside because this is a content of the cavity. So this is malleus. After malleus we have incus, and then we have stapes. And now this stapes will come and attach here like this. Good? And the purpose is the movement in the sound will create movement in the tympanic membrane. The tympanic membrane will move movement, the malleus, then incus, then stapes, and then stapes will push here to make a vibration or oscillation in the perilymph, which contains the endolymph. After this, we have a cochlea. Cochlea is like this. If you open the cochlea, I have another picture to show you what will happen in the open cochlea. Try to remember there's perilymph and endolymph here. There's another opening here called a round window. It is covered with a special structure, membranous structure, and the name is secondary tympanic membrane. So we have a primary or the tympanic membrane, and we have a secondary tympanic membrane. The pressure which was exerted from here will go inside, move the perilymph, move the hair cells to generate a sound wave that will go into the pons with the cochlear part of vestibulocochlear nerve, and then the pressure has to be neutralized. So here is a tympanic membrane, the pressure will go and pressure will come back. So this may have some movement to neutralize this pressure. Am I clear?
Yes.
Again, promontory, this facial canal, this is what we called as one of the impression of semicircular canals. Which one? The lateral one. Now we have chorda tympani is one of the content, the plexus is another content, muscle with a tendon. This muscle is coming to this side. Why it's coming here? To attach to malleus, which is on the tympanic membrane. Am I clear?
Yes.
Then we have opening for auditory tube, Eustachian tube, no problem. Here is the carotid. Not directly related, but it's present just adjacent. Here is the editus. I told you meaning of editus is the opening. After that we have antrum, the cavity, and after that we have mastoid air cells, air cavities. Am I clear?
Yes.
So this is all about the boundaries. Any question from the boundaries of middle ear?
You forgot the pyramidal eminence.
This one, okay. What is this for? This is an eminence to which a very small, the smallest muscle, skeletal muscle in the body is attached. Stapedius. Both of them, this and this, will help the over oscillation of tympanic membrane, and the ear damage is prevented.
Okay.
Clear now?
Clear.
Great. You should remember the contents, and here is the table to show you the contents, all of them, and there are some small details, and we have described them in the theory, no problem. But don't forget, here is a normal content of middle ear cavity, and that is the whole story for creation of the tympanic membrane and Eustachian tube, because the air pressure has to be equal on both sides of the ear, outer and the middle ear, it should be equal. And that is the reason I told you, when you have longer flights or something and you have blocked ears, or when you have flu like Zukam or something, you have blocked ears because the Eustachian tube is blocked and the pressure difference is created. That is the reason. Clear?
Clear.
Okay. Then I told you about the cochlea. This is the cochlea part, this is vestibule part, and we have three semicircular canals.
Okay.
Cochlea is the organ of hearing. It has hair cells, and vestibule has two structures. Saccule. Saccule, here wala hair. Near to cochlea is saccule. Then is the utricle, and then is the semicircular canals. Okay. So these 1, 2, and 3, here, here, and here, are some receptors. Histology people must have told you regarding the receptor stationary and movements and everything. You know better than me now. So this is the bony labyrinth or bony cochlea, bony area. Inside we have a similar membranous structures. So cochlea has a cochlea-like bony membranous structures. Then we have saccule in the vestibule, and then we have utricle, and then we have a membranous. The fluid is around them, perilymph. The fluid is inside them, endolymph. How this is created? The fluid. There is a structure called ductus endolymphaticus. Because we should have some source for these fluids. A minimal change in the sodium, potassium, and calcium concentration can give you a diseases like Meniere's, vertigo, and vomiting, and many other things. So this is called ductus endolymphaticus. It goes into a sac of lymphatics, and this sac is very close to dura mater, which is very close to arachnoid. So it is believed that the exchange of material keeping the sodium and potassium concentrations in good is taking place at this area of, like, when I believe this, I think this is like a placenta of the ear, because here is the fluid and absorption and reabsorption and secretion is being taken place. So I believe like this.
Yes.
So this is like a sac, then ductus endolymphatics. It is near to the subarachnoid space, of course the dura mater, not inside, but with the diffusion and the amount and the concentrations of various ions and elements is contributed by this endolymphatics. We will show you here. Okay, ductus endolymphatics with a cyst. Am I clear?
Yes.
This is where we will find the internal ear. This is the area. Petrous part of temporal bone. When I see the skull, I don't find internal ear. Okay?
Yes.
I have to dig. I have to scratch to reach into the internal ear if you want to see it. That is the reason diseases will be very difficult to treat, because we can only cause the medicine to reach there. I wish there should be some receptor and a medicine should go and directly act there. I wish. Okay. Then we have, this is very clear to you, no problems. Here is a picture of one of these models, external auditory meatus with pinna, and I told you the first part of the tube is cartilaginous and then there is a bony part.
Yes.
Then we have a tympanic membrane which is removed here to show the area of the cavity. Then in the front wall, anterior wall, one opening, another opening, and a canal for carotid. Okay, so here is tensor tympani, here is Eustachian tube or auditory tube. Good, communicating with the anterior wall. Posterior wall, I told you it must have an opening to go additus, to go back into the mastoid, and then after the mastoid we have some upper part, attic part. No clinical issues. Am I clear?
Okay.
Then this is the posterior wall. Anterior wall, posterior wall is very clear here. The roof and the floor, they are again clear. Eustachian tube has a bony part to start and a cartilaginous part to finish, and this will go into the nasopharynx to equalize your pressure. This is the same thing. Here we have removed the petrous part of temporal bone to see inside the inner ear. I will show you in a while. Nothing new in this model, I think, except we have this styloid process. We have this mastoid process, and we should have a stylomastoid, and there is a fascial nerve. Okay? There was a question yesterday, so that is the reason I raised this story because one of the student in the lecture, he's told me that the facial nerve is the content of the cavity. No, facial nerve is not the content of the cavity. Facial nerve canal impression is there. So I added this information. The facial canal is a Z-shaped canal running through the temporal bone in the internal acoustic meatus to the stylomastoid foramen and approximately 3 centimeters long, which makes the longest human osseous canal of a nerve. Actually, the question was, the nerve is getting out of the stylomastoid foramen. From where it is entering? Yes, here is suppose the internal acoustic meatus. It has 3 important contents, rather 2. So one is vestibulocochlear nerve and other is facial nerve. So he was confused that facial nerve entering here is the content. No, it is making an impression on the back. Of course, one of the branches, chorda tympani, is the content. Am I clear now? Great. 3 bones in the ear we have, malleus, incus and stapes. This is the head of the malleus, this is one lateral part of the malleus, this is handle of the malleus. Of course they have joints because they have to move. And of course the joints are secured by the ligaments. So subhanallah, even if you see how much is the size of the bones, like this, If you keep them 3 on the hand, on the finger, they are like this, 3 lines. And still, subhanallah, the joints, the ligaments, their movements and their ability to increase the efficacy of sound and we are hearing. So here is the malleus. After malleus we have stapes. The stapes looks like this. The stapes look like this. This is called foot plate of stapes. This is called crus of stapes. So the stapes will join the oval window. Agree?
Yes.
Clear? Nothing new. Here is a portion where we can see at least tympanic membrane. In this model we can see at least the tympanic membrane. We can see other, not very clear, but at least we can see this is incus probably and this is stapes. We can see the cochlea. We can see vestibulocochlear nerve. This is the cochlear part. This is vestibular part. This part is arising from cochlea and this is arising from vestibules, yani, and semicircular canals, and then they will come together and make a common vestibulocochlear nerve, which will leave this through internal acoustic meatus and will reach the pons here. Am I clear? You are getting this? Good. Then this is not your objective, but just to show you how it is working. The ear is working. Here is a sound wave going to vibrate the malleus, then incus, then stapes on the oval window. Now this is the right place to show you. This is the cochlea like this. And if I open the cochlea, how you will see it is like this. Okay? So here is the oval window. The pressure will goes the fluid. The pressure will come here. Of course it will be decreased. To minimize this pressure, here is secondary tympanic membrane which will just bulge out and to finish. Otherwise I will keep on hearing the sound. Okay? Like there should be a snooze button somewhere. So this is like perilymph, blue one, endolymph, and then we have the organ of Corti and composed of hair cells and everything you know better than me in histology. And then these cells will generate through the nerve impulses will be captured here by the cochlear part and will go. Clear now?
Clear.
Nothing new. Regarding one important step here, more probably the slide is missed or somewhere. Yes, clinical elements. This I read. Otitis media. Acute otitis externa. What is otitis externa? Inflammation of the external ear. So it can be on the pinna, it can be in the tube before the membrane. Otitis externa. Otitis media is the inflammation of middle ear cavity. Otitis interna is the inflammation of the inner ear. Okay? Otitis externa will give you pain because I told you that the skin is fairly adherent to the cartilage and there is no gap. If there is a trauma, bleeding or something, there is hardly any space for the blood to be collected or pus to be collected. So even a small boil after a bacterial infection, even a small will give you a lot of ear pain because of non-availability of the space to expand. Am I clear?
Clear.
So this is for externa. Then we will have a wax ear. What is wax? Wax is a normal secretion of the gland lining the tube and that is there to protect us from infections, any element entering or any insects or something. You are sleeping and some insect is crawling inside. The smell, it has a special smell. Though that irritates the insects and they get out. This is another benefit. Then we have IgA antibodies in it that is protective us against bacteria, virus and fungi. And of course, but never try to clean it with.
The weird part, doctor, they think it's a waste.
It's a waste thing, yes. Initially, and then even don't use the earbuds to clean it because you are just making layer on the layer. You are just packing it. Don't pack it. If this is more than excess, sometime in the dry weather it will come out and you have all this experience. This is the wax ear. If this is so much that it is hampering your sound, giving you a feeling of vertigo or giving you hearing abnormalities or vertigo or ear ache, Then of course we can have some drops to make it softer, and we have a suction to suck it. Don't try at home. Okay. Then otitis media can be acute and chronic.
Clear.
Chronic, if the pus is staying, abscess is, or the inflammatory material is staying here for longer time, maybe 6 months, 6 weeks more than, it's labeled as chronic otitis media. And one of the bad complication is rupture of the tympanic membrane. But I don't say it's a bad complication. I would say it's a blessing. Rather than to go for a brain, for thrombus, for otitis, mastoiditis, it is better that Allah subhanahu wa ta'ala relieves the pressure by pars flaccida, and at least the pus is coming out. Now here was the question that will it heal? Yes. It usually does not heal. We try to use antibiotics and anti-inflammatory drugs, systemic and local and everything. But sometimes it does not heal, depends upon the size of the rupture. But it usually, because it is only in the pars flaccida, which is a smaller part, the hearing usually is not affected. Until a time comes when it is very big or you have a hearing, we can repair it. From where we should enter? This is the question for you now.
Repair the tympanic membrane.
Repair the tympanic. From where? Yaad brother.
Nose.
Nose. It is like going to Riyadh via Makkah.
No, from the external ear.
Empty of nose.
No.
From the external ear.
From the external ear. Repair with what?
Radiation.
Take a new curtain, put inside. We make a cut here on the back of the ear. External ear is lifted back like this. We reach to the tympanic membrane. So I'm on the tympanic membrane now. The ear is shifted here. Okay.
Entering from the stage.
Now there is a temporal fascia, temporalis muscle. So I take a part of temporal fascia, make it connected, repair it, back, put the ear back, and clear?
Clear.
This is the path. Usually advised by the surgeon. Am I clear now?
Yes.
Good. So let's take the attendance first. Anyone from group A? In this external acoustic meatus, what should I see? This is a plastic model. In a real skull, what should I see?
Tympanic membrane. From the.
Ideally, it should be tympanic membrane.
Yes.
But since the skull is without any ear or anything, so external ear has been removed completely. Maybe a remnant of tympanic membrane. And if there is no tympanic membrane, what should I see?
The bones.
Which?
The meniscus.
Okay. When we remove the tympanic membrane, they are attached to it and they will be removed. And oval window and promontory. So the most obvious thing I will see if I have to see in a normal ear. Okay, I told you how to examine the ear because I told you the tube is not straight.
Yeah, you should like.
So you are unable to see it. It is S shaped. But the S is not like S is like this. Agree?
Yes.
So if you insist on seeing, you will see here. So you have to pull the ear back and lateral to make this S straight, and you will be able to see with a torch the tympanic membrane. It's fairly beautiful thing to see. And on clinical examination, I would love to come for that. So here I should see the medial wall, and medial wall has a promontory. Then it has a impression for facial canal. I told you. Then I told you there is a semicircular canal impression. Then oval window. Then round window. Then so ideally we should see the medial wall, but this is a plastic model.
Okay.
So external ear is finished here. Nothing. Where is internal ear?
Petrus.
Where is Petrus part? This rough is the Petrus part. This rough is the Petrus part. So this is the Petrus part. I should dig out like this to see into the ear. So this is, I should say, as internal ear.
Shouldn't that be difficult?
And then, of course, it's impossible. I cannot reach into the internal ear at any cost. I should remove the brain, keep it here for half an hour, work on the ear, put it back. Impossible. Okay, so that is the reason that diseases like chronic Meniere's and others are chronic, and I wish I could have a drug with a receptor to reach alatul there.
Also, doctor, with basoscular fractures also affected. So.
But yes, if so, that is the reason CSF autoria is possible. So this is about this. The auditory tube opens here. This is the nasopharynx. After nose, here is the nose. Behind the nose, we have this all is pharynx. We have nasopharynx behind the nose part, nasal cavity. Behind the oral cavity, we have oropharynx, and behind the laryngeal cavity, we have laryngopharynx. So here is the nasopharynx, and this is the opening of auditory tube. To balance from here inside, and it will help you to balance it equalize the air pressure on the two sides of tympanic membrane. Then we have these three bones. The malleus with area for articulation here with the incus, and then we have a stapes. So here is the foot plate of stapes, which is there to fixed on the oval window. Sometimes there is sclerosis, it is fixed, and there are many other pathologies you will learn in pathology. So these are the three bones which are there to make the sound augmented. After that, we have a tympanic membrane, okay, or a bigger one. Tympanic membrane. Along with tympanic membrane, we have three bones, or sometimes two bones united, here two, here again two, because the third one is attached here to the oval window, stapes. Okay, so this is malleus incus. I have this another structure here, or this red structure, tendon of tensor tympani. Of course, because this is the tympanic membrane. Here, like attached. Here is the tensor tympani going inside in the cavity, and then it is attached on the malleus. So this is the tendon of tensor tympani. Of course, it has a pars tensa. Then the annulus, which has the thicker part to be fixed, annulus, and then here's anterior posterior malleolar folds, and then we have pars flaccida, which is not very obvious clearly here. Am I clear for this? So this is the position. Now, this is the styloid process. Do we have a mastoid? Not yet. Okay. Then here is the petrous part of temporal one. I removed it to show you the inner ear. So here is the inner ear. Except there is a malleus, stapes is included here in this model. So if I make it like an anatomical position, it is like this for this ear. So we have a superior semicircular canal. We have, what are the parts? Cochlea.
Yes.
The cochlea is a bony part, and it is rounded like this on a bone, small bone like this, called modulus. So it is covered, it is like this. So this is cochlea. I hardly see any modulus in any of them, so nothing here. So this is cochlea. After cochlea, we have this small vestibule, and after vestibule, we have three semicircular canals. Okay, so one is the superior one. When you put it like this, anatomical position, the one goes up is the superior one, the one goes back is the posterior, one goes towards the tympanic membrane is lateral. Okay, remember like this. So one goes towards the tympanic membrane, this is going towards is the lateral. So superior, posterior, and lateral. If you open them, this is called bony labyrinth. Then if you open the similar sort of structure, you will find a membranous labyrinth surrounded by perilymph inside endolymph. This is what is stapes placed where?
Over window.
Oval window. So we have a round window here.
What is that?
Wow.
Round window. A small round window. Here. Secondary tympanic membrane will cover it. Okay. Yes. What I can see else is a two nerves in combination. The Assalamu alaikum. The cochlear nerve arising from cochlea, and we have vestibular part. So combined, we have vestibulocochlear nerve. It will get out of internal acoustic meatus. So this is internal acoustic meatus. Where is the internal acoustic meatus? Here. Good. The tip is inside the internal acoustic meatus.
Yes.
Good, Shiva?
Good.
Okay. So this is internal acoustic meatus, you can see here. So this is the area from where it will get exit, and here is the pons. So it will go into the pons. And here is the facial nerve from midbrain or brainstem will enter in here, and then it will reach the middle ear cavity as an impression, not a nerve, but with the other contents, you know that. Nothing left in this model, I believe. Then we have here, this is the styloid process. This is the mastoid process. Here you can see the tympanic membrane. Okay, let us remove the petrous part of temporal bone, some part of it, to see all the structures of the ear. So here is the external ear with pinna, and you know the helix, antihelix, tragus, antitragus, notch, insusura, everything. And here is the lobule. Then we have a canal. After canal, we have a tympanic membrane, which is actually the lateral wall.
Okay.
Then we have, here's the floor, roof, here is the floor. And then we have a auditory tube. And then we have a tensor tympani, if someone wishes to see, tensor tympani. And here is the opening of Eustachian tube into the nasopharynx, here. Here we have carotid. Not a direct part, but it's related.
Related.
This has the same structures which I told you.
What is the stapedius muscle?
Stapedius is not visible in any of the models.
Okay.
Only we have to know that there is a pyramid, and on the tip of the pyramid there is stapedius attached to. Can I have this
It's
bone
one of
part?
the content.
It's one of the content, and it is attached to one of the crusts here.
Okay. So it
Stapedius.
should be on the
Yes.
stapes.
Yes. So, khalas na. Huh. Here is the, what I told you, ductus endolymphaticus, this one. This, ductus endolymphaticus. And of course it should have a sac.
A sac.
Here is the sac. So here is the ductus endolymphaticus, should be connected like this. Here is the sac with the temporal part, and it, you see here is one of the sinuses crossing. So near here is the dura and others, so it can have regulation of the fluid. Am I clear?
Clear.
Doctor, do they
Anything?
bring a huge model for the